Welcome back, everybody. David here again with Med School Boot Camp. So in this next video, we're going to talk about another very important pathology, and this one is called osteosarcoma. So if we can draw your attention to our kind of overview image of the primary bone tumors, which shows the locations that these tumors show up, we can see the osteosarcoma is located in this area right here. And so that's primarily going to be in that metaphysis region of the long bone. And again, this is important because a lot of times they will give you the tumors, right? They will let you know it's a bone tumor, and they'll differentiate them by where they're located. Are they in the diaphysis, or the longest portion of the bone? Are they in the metaphysis, or the middle portion? Remember the M in metaphysis for middle. Or are they more likely to be located at the epiphysis? And again, the E in epiphysis for the end of the bone. This is a really important differentiating factor between these bone tumors, and that's why it's so important to know where's the primary location, where's the most likely location in the bone for these tumors to form. And so if we think about the epidemiology for the osteosarcoma, this is a malignant bone tumor. A lot of the previous tumors we've talked about in this chapter have been benign bone tumors. But here we're starting to talk about malignant things. In general, things that are malignant are more likely to spread or metastasize throughout the body or become locally destructive to the surrounding tissues. And so we'll see when we talk about the management here, these are more likely things that need to be treated a little bit more aggressively with surgical intervention or potentially chemo and radiation. Contrast that with some more benign tumors where we said if they were asymptomatic, the patient may not need treatments. If a tumor is just found to be there and it's not causing any symptoms, it's a known benign tumor, it's not likely to keep growing and become a problem for the patient. It could just be there and remain, or watchful waiting can occur until things change. But with a malignant tumor, we have to think a little bit more further down the line and think that these tumors are likely to cause bad problems for these patients, so we need to address them as soon as they are found. It's also important to know that this is going to have a bimodal age distribution, typically around 10 to 30, so teenage years to young adulthood, and then greater than 60 or some of our older years. And what that means is if we think about it, right, there's essentially a low incidence of patients having this disease, and then there's a spike. There's a lot of people that are having this in the 10 to 30 range, and then it kind of quiets off in that 40 to 50 range, and then there's another spike again. We call this bimodal. Bi means two, and we have two primary areas where this disease pops up again. As I always say, this does not mean that 40-year-old can't have this disease, but classically, these are the typical age ranges we think about for patients having this condition. Now, they also like you to know that patients can have primary osteosarcoma, which has an unknown etiology, as in we don't know where it comes from. It's just the primary disease that the patient has. However, secondary osteosarcoma typically is related to a patient having some other condition. So patients who have Paget disease of the bone, patients who have radiation exposure, bony infarcts, potentially retinoblastoma, Li-Fraumeni syndrome, or patients at elevated age are more likely to have this condition as well. It's a secondary condition, or a secondary osteosarcoma. There's one of these things going on. This is the primary condition, and the osteosarcoma is the secondary thing. It's because of one of the primary things, they have the osteosarcoma. So hopefully that makes sense. And just as quick reminders, Paget disease of the bone, remember, is characterized by rapid and progressive bone turnover. There's so much bone turnover that a bunch of bone gets formed, but it's poorly formed bone. And so it makes sense to us, right? If excessive bone turnover is occurring or extra bone formation is occurring, well, what could happen? You could develop a bone tumor, such as an osteosarcoma. Patients who have excessive radiation are also at increased risk, or patients with bony infarcts. So bony infarcts could be due to trauma to the area. Recall, corticosteroids can cause osteonecrosis or other things that can cause interruption to the blood supply to the bone, can increase a patient's risk for osteosarcoma. Retinoblastoma is an ocular genetic condition which is associated with the tumor suppressor gene RB1, where patients can get tumors in their eyes, and they can also get tumors other places in their body, such as their bones. And then finally, Li-Fraumeni syndrome, recall, is an autosomal dominant condition where patients get an inherited mutation of a tumor suppressor gene, TP53 in this case, and they are basically predisposed to all kinds of tumors and cancers throughout the body. Now, when we think about the presentation here, we talked about the region this typically presents. It's usually in the metaphysis of the long bone, near the knee region. And so again, this is why it's important to know specifically where in the long bone, because a lot of the tumors we've talked about, we say they're kind of developing in the tibia or in the femur near the knee region is where they like to test these. And so we need to specifically know which part of the bone, diaphysis, metaphysis, or epiphysis. So in this instance, we are most likely to be dealing with the metaphysis. As with many other tumors, this can have localized pain, which can be worse at night. This can include swelling and decreased range of motion. Again, if you have more swelling in the joint, that can decrease the amount that you can move the joint or decrease the range of motion. These patients can also have pathologic fractures, and we talked about that previously, but just as a reminder, a pathologic fracture is a fracture that would occur in a scenario we wouldn't otherwise expect it to occur. So a possible example is somebody takes a step off of a stair. We walk downstairs all the time. Usually you don't break your leg. But if somebody steps down the stair and fractures their femur, this is a low energy mechanism of action for a fracture to occur. And so when things like this occur, when a fracture occurs to a very minor injury, this is often due to underlying bone disease or poor bone formation, leading to the fracture or predisposing the patient to having higher risk of the fracture occurring. Now, it's also important to know these patients could have potential B symptoms, right? And recall, our B symptoms are fevers, night sweats, and unintentional weight loss. At the end of the day, this is a cancer, right? It's a bone cancer. It's different than our blood cancers. It's different than a brain cancer, but it's still a type of cancer. And so B symptoms are definitely things that patients can present with, and they would require further workup from the clinician. Now, if we turn our attention to the diagnostics here, some really high yield and important things they like you to know on test day. So they want you to know the imaging findings, or the x-ray in this instance, and the histopathology, in addition to some of the serum labs. So if you draw your attention over here to our x-ray, there's going to be some key findings they want you to know. First, let's orient ourselves. Up here, we have what bone? The femur. Up here is the kneecap or the patella. Here we have the tibia. And over here, this skinny bone is the fibula. So now that we've kind of oriented ourselves, let's talk about some of these findings. The first is going to be the sunburst pattern. And some of these kind of overlap with each other. They just have similar names. But the sunburst pattern refers to a pretty unique finding. So if we're looking at the tumor right here, the sunburst pattern is what's defined as a periosteal reaction that lifts the periosteum from the bone. And so this occurs when the bony lesion grows too quickly that the periosteum essentially can't keep up. And you'll kind of see this spiculated appearance, or these kind of fibers of bone tissue that are pointing out like this. So the idea is that it looks like a sun that's kind of coming over the horizon. And again, this is due to an incongruence between the rate of the tumor growth relative to the periosteum. The periosteum can't keep up. The tumor gets bigger and bigger and bigger. And as it does, the bone essentially stretches out this way, leading to this sunburst appearance, or these fibers that are being elongated in the bone. Now, when we think about Codman triangle, this is due to the periosteal elevation as well. Again, kind of a similar thing. And this is again referring to kind of that periosteum that's being elevated from the bone itself. So same thing over here. We can appreciate up here we have normal bony contour, and then we see this stark elevation, or this increased rise in the periosteum. So this is kind of the idea of the Codman triangle. And finally, we have osteolysis, which can also be called a moth-eaten appearance. And you'll see we have this in a few different tumors, right? Anytime we have osteolysis, it can kind of present this moth-eaten appearance. So if you kind of look at this whole thing, you can see how there's some really white areas and then some kind of darker areas. And so this is the appearance that has kind of been eaten at by moths, or that moth-eaten appearance. And this is again due to osteolysis. Bone is being destroyed in certain areas, or osteolysis is occurring, and that's what's creating these areas of darkness, right? Remember, on a classic radiograph or an x-ray, areas of darkness are not going to be bone typically, whereas the lighter or whiter areas are going to be our bone. Now, when we think about the histopathology here, they want you to know this is going to have pleomorphic osteoid-producing cells, sometimes also called malignant osteoblasts. So what does that mean? Well, let's draw attention to our pathology image right here. So first, they're saying these are pleomorphic. Pleomorphic just means that it's variable. It's variable shape, size, and staining patterns. So the key ones I want you to draw your attention to is this area right here. So you can appreciate some of these cells stain darker or lighter than others, right? There's also variation in the size. Just look at this bunch right here. Some are smaller than others. Some are larger than the ones next to them. And shape. Some of them are more circular shape. Some of them are more oblong or oval shaped. And so that's what pleomorphic means here. Now, these are osteoblasts. And what does that mean? They build bone. Remember, the B in osteoblast stands for build versus the C in osteoclast stands for consumes. So these are malignant, right? Because these osteoblasts are building too much bone. They're building excessive. That's why they're called malignant osteoblasts. A normal osteoblast is helping bone remodel. It's good. But when it gets out of control, when it gets to be too much, now we've created a bad process. We've created a malignant process in the body. And so if you see a question stem referring to pleomorphic malignant osteoblast, this is typically what they're referring to in that question. And finally, it's also important to know that you can have elevated ESR, LDH, and alkaline phosphatase in this condition. Again, this is not going to be as specific for this pathology, but it could be a supplemental piece of information that the question writers give you to kind of nudge you in the direction of the osteosarcoma. And just as a real quick reminder on what these are, alkaline phosphatase is an enzyme that's found throughout the body, particularly in bone. And so when we have extra bony processes occurring or bone tumors being formed, it's reasonable to think this could be an elevated enzyme near that area. LDH, remember, is lactate dehydrogenase, and ESR is our erythrocyte sedimentation rate. And this is a serum marker that can be elevated in a variety of different conditions, including infections, inflammation, or malignant conditions. Now, when we think about our management here, remember, we said this is a malignant bone tumor. So we're going to have to think a little bit more aggressive than some of our benign bone tumors. And the key here is that it depends if this is a primary cause or a secondary cause. We talked about this earlier in the video, right? Draw your attention back up here. We said that primary cause unknown, secondary cause, lots of potential etiologies. But the key point is that the primary cause is going to respond to surgery and chemotherapy. It's often resistant to radiation therapy, but the point is that we have good treatment options. We have things that we can do to help out these patients. In contrast, our secondary causes have a poor prognosis. The things that we can do to treat these patients don't seem to work near as well. So if these are one of the underlying reasons for the patient having osteosarcoma, overall, the long-term prognosis currently is going to be worse than somebody who has a primary osteosarcoma or an osteosarcoma that is not due to something else. So a possible question that they could ask you for this condition includes something along the lines of an 18-year-old patient presents to the ED with distal thigh pain for the last several weeks. The pain is progressively worsening and affecting his ability to sleep comfortably at night. On physical exam, there's tenderness and swelling around the affected area. The question could then ask which of the following imaging modalities would be the most appropriate to work up this patient's chief complaint. Now, they can give you a lot of different imaging modalities. They can give you a CT scan, they can give you an X-ray, an MRI, and an ultrasound. The key here that the answer for this question is going to be the radiograph or the X-ray. It's going to be the simplest, it's going to be the fastest, and you're going to be able to notice something like this on a radiograph. You don't necessarily need a CT for this. It's not a soft tissue thing. And again, an X-ray is the fastest, least expensive option to primarily work up this patient's condition. Now, that's not to say you can't get an MRI down the road for surgical planning. If surgical removal were indicated, right, a patient were going to have surgical intervention, then an MRI could be indicated. But the first thing you want to do, particularly in the setting of the emergency department, is to get an X-ray image of the patient's affected area. All right, so just a quick summary of this video. We're talking about the osteosarcoma here, right? This is one of our malignant bone tumors, has a bimodal age distribution. We talked about what that means. Primary osteosarcoma has an unknown etiology. Secondary osteosarcoma has many potential etiologies. Presentation here typically going to occur in the metaphysis of the long bone, often near the knee region. Patients are often going to present with pain, swelling, and decreased range of motion, and potentially could be presenting with a pathologic fracture. Plus or minus some of the B symptoms, right? Fevers, night sweats, weight loss. Because this is a cancer, although it's a bone cancer, patients can still present with these classic cancer symptoms. Diagnostics here, key points to keep in mind, the X-ray findings, right? We talked about what those are over here. This is very obviously the pathological region, but here's a couple of buzzwords they like you to know: the sunburst pattern, the Cosman triangle, and again, these are all due to the periosteal reaction. Bone is growing too much outwards, periosteum cannot keep up, and then we get some of these classic findings. Patients can also present with some osteolysis that presents with a moth-eaten appearance. Histopathology, we have pleomorphic, right? Varies in size, shape, and staining. Osteoid-producing cells, often called malignant osteoblasts. Why are they malignant osteoblasts? Because they're osteoblasts that are building too much bone or an excessive amount of bone to the point that it's considered to be a malignancy. When we think about the management here, primary causes are going to respond well to surgery and chemotherapy. Secondary causes are going to have a poor prognosis relative to primary causes. For the management here, right, primary causes are going to respond well to surgery and chemotherapy. However, secondary causes are going to have a poor prognosis.